Cardiovascular disease in women, underdiagnosed and undertreated. Cardiovascular disease affects 6.6 million women in the United States annually and is the leading source of morbidity and mortality among women. Among women diagnosed with cardiovascular disease, 2.7 million have a history of myocardial infarction or heart attack. Each year, more than 53,000 women die of a heart attack and 262,000 are hospitalized because of cardiovascular disease. 1 in 4 female patients presenting with a first myocardial infarction will die. Cardiovascular disease in women remains underdiagnosed and undertreated due to the diagnostic challenge it presents, as well as the persisting attitude that cardiovascular disease predominantly affects men. Gender-related risk factors have now been identified, but there is a lack of clinical application, leading to the misdiagnosis and poor management of women with cardiovascular disease. Anatomically, women have smaller hearts even after adjustment for body size, and, as a result, have different disease phenotypes, which may influence the choice and accuracy of diagnostic tests. Further, there are intrinsic imaging difficulties with standard transthoracic echocardiography in women due to reduced image quality from breast tissue attenuation and reluctance to use cardiac computed tomography in premenopausal women due to breast tissue sensitivity. Women present with ischemic heart disease about a decade later than men. This usually occurs in the postmenopausal period, during which time the protective effects of estrogen are attenuated. Furthermore, population-based risk reduction in women has not resulted in improvements in the incidence of cardiovascular disease compared to men. In recent years, there has been a significant decline in the incidence of myocardial infarction in men, and a comparative increase in the incidence in older women. Further evidence supporting this finding from the National Health and Nutrition Examination surveys demonstrated an increase in the prevalence of myocardial infarctions in women in the 35 to 54-year age range, while a decline in prevalence was observed in age-matched men. It follows that early and accurate diagnosis of cardiovascular disease is pivotal to reduce mortality rates in women. Women share many traditional risk factors with men such as diabetes, smoking, and high lipid levels. However, they also have sex-specific risk factors including pregnancy-related complications such as preeclampsia, gestational diabetes, and preterm birth, all of which increase future cardiovascular risk. Menopause and the loss of estrogen's cardioprotective effect also increase cardiovascular disease risk. Autoimmune diseases like lupus and rheumatoid arthritis are more common in women and further increase the risk of cardiovascular disease. Common disorders of young women like polycystic ovary syndrome are associated with obesity, diabetes, and metabolic syndrome, also causing an increased lifetime risk of cardiovascular disease. Cardiovascular disease in men is very different, often leading to diagnostic confusion since the male model is routinely used as the paradigm of cardiovascular disease. Men are more likely to have obstructive cardiovascular disease, specifically large plaques causing blockage of the large coronary arteries. Women, on the other hand, are more likely to have microvascular disease and plaque erosion. There is overrepresentation of women with MI or heart attack with non-obstructed coronary arteries, MNOCA, relative to those with elevated troponin, a protein marker of cardiac damage, resulting from obstructive coronary artery disease. Only 24 to 30% of women present with obstructive cardiovascular disease. Mechanisms of MNOCA that are more commonly observed in women include coronary microvascular dysfunction and coronary artery plaque erosions. New and more sophisticated diagnostic testing should be made universally available for women to more accurately diagnose underlying cardiovascular disease and prevent unnecessary morbidity and mortality.